Just while you're all logging in, I'll explain how this afternoon's going to work. So I'm Chelsea. I'm from GPSN Monash. I'm also on a GP rotation at the moment. I'm a final year and it's my clinical elective. So this afternoon we'll start with this EMQ session. There's about 45 EMQs in this Socrative quiz. We'll try and I'll give you about 30 seconds maybe per question, and we can have a bit of a discussion as we go along. If you have any questions, please feel free to ask. You can just put up your hand or shout out Chelsea if I don't notice that your hand's up, that's okay. If you don't want to ask, that's fine. You can send me a Facebook message. I've just posted the room code in the event page, so that's who I am on Facebook. Or you can send me an email, cnmat2. Similarly, if you ask me a question and I don't think I can answer it on the spot, I'll get back to you on it rather than give you the wrong answer. After we finish with the EMQs, we'll move across to 27 Rainforest Walk and go to the tute rooms to practice the OSCEs. So there's 4 OSCE stations. Generally, I recommend that you work in pairs. You can work in groups of 3 if you're more comfortable with that, but you get a bit more practice in pairs. We've got, hopefully, if security pulls through for us, both levels of 27 Rainforest, which means you can have about 10, 12 students in each room, which is a nice number. So as I said, there'll be 4 OSCE stations, 2 minutes of reading time, 8 minutes active and 2 minutes feedback. So all up 12 minutes per station, and we'll be doing the timing, myself and 2 other GPSN students. And then we'll just roll from one OSCE station to the next. So it's going to be back to back, no breaks, which the idea is we're just really trying to create that stressful OSCE situation that you will experience at the end of the year, which is why I recommend that if you can try and stick around for the OSCEs, you can always take them home and practice them. But I find it's useful when you're not in control of the timing to have that experience and become comfortable with that, because that's how it is at the end of the year. Between finishing the EMQs and moving across to practice the OSCEs, I'll just quickly run through a 10-step management plan for those who haven't done GP or who are rural and haven't been taught that in their teaching. It sounds very daunting, but it's not, and you probably won't be able to memorise a 10-step management plan today. That's okay. You can get through the stations without using it. Alternatively, I've put it up on the Google Drive with the stations, and you can have that open if you'd prefer to refer to it while you're practicing. But at this stage, it's more just being aware that that's there, and we'll talk a bit more about it. But by the end of the year, you want to be able to use that in your OSCE stations. Any questions before we get started? Yes. Yes, I've just got to work out how. But yes, it all exists in a Word document that's very messy, but it should be able to get uploaded at some point. Yeah. Anything else? All right. Well, we might get started. If you haven't logged in, just go to the Facebook event page. The code's there. In fact, I think you can just, there you go. 43 out of 70 students have answered. All right. So you just scroll down and then all your options there. Is it working? 43 people have answered. Okay. Maybe once we've reached the critical mass of like 65 students as well, we'll just keep going. Also, I need you to use your imagination and pretend this is a left ear. So Google Socrative and then click on student login, and it should ask you for a code. And that code is up there. Okay, I'm going to move on to the next. I'm going to go to the answer of this one. Oh no. Okay, I'll go back. That's not what I was. How did we do? That's the button. So it's perichondritis of the external ear, and that's because it's confined to this portion, sparing the earlobe, so just affecting the cartilage. Otitis externa, you wouldn't see this really sharp demarcation with affected and unaffected areas. Oh, and a very extremely tender inflamed area. Okay. There we are. That was 30 seconds, might give you a bit longer than 30 seconds. Okay, in the interests of time, I think I'll get to 70 students and then, okay, there we go. How did we do? Oh, all right. Yes, so this is secretory otitis media. So what you're seeing here is fluid in the middle ear without acute inflammation. So it's not acute otitis media, but that fluid is still there. So causes hearing loss, and it's over a much longer time period than an acute inflammation. Eustachian tube dysfunction, I'll hold off talking about that because I think we have a question coming up. Treatment for this is either waiting and seeing, so it's extremely common at 8, 10, even 12 weeks post-acute otitis media to have a bit of fluid remaining. It's only if it's been going on for 6 months, or if it's 3 months and it's bilateral, then you might consider grommet tubes. Or if someone has risk factors, if particularly a child with risk factors for a language disorder or learning disorder, like they have a developmental delay or Down syndrome, then you would consider inserting grommet tubes earlier. Otherwise, it's very much waiting and seeing, and it depends largely on the impact on the child. Right. So yes, middle ear barrow trauma. No perforation in this tympanic membrane. There's just a lot of hemorrhage, which is what you're seeing there. Really, the key line here is that he returned from Japan a week ago. So recent travel, that's what you're looking for there. At the time, there may be some pain and discharge, but then once that resolves, it's just a decreased hearing and tinnitus that persists. Okay, let's see. Yes, so this is eustachian tube dysfunction. So on history, it's that popping sound with swallowing or yawning and a conductive hearing loss on the right side, which means that Weber's test lateralizes to the right and Rene's is negative. It's a normal tympanic membrane when you look at it with an otoscope. So acute labyrinthitis, on this examination, it's a sensory neural hearing loss on the right. And so in someone who has this post-influenza type illness, vertigo and nausea, you're thinking either acute labyrinthitis or vestibular neuronitis. If there's hearing loss, it's acute labyrinthitis. There shouldn't be hearing loss in vestibular neuronitis. Otherwise, very similar clinical presentation. It's self-limiting. You treat with prochlorperazine or Stemetil for the vertigo, and debatable whether you would give prednisolone as well, but that's an option. So this is Meniere's disease, got these recurrent episodes of vertigo, nausea and tinnitus, and an asymmetrical sensory neural hearing loss. So you can see bone and air conduction are both impaired, and it starts off at lower frequencies. As it progresses, it can become bilateral and extend to the higher frequencies as well. This would be an early picture. Treatment, prochlorperazine, again, symptomatically when there's vertigo, otherwise lifestyle modification, reducing caffeine and salt intake, and then your next step would be to prescribe a diuretic such as hydrochlorothiazide. And again, beta-histine is something that's been used in the past but doesn't have a lot of evidence for it. I think I'm going to have to lower my threshold of number of students answering before I move on, because otherwise I think we'll be here for a while. Might drop it. Oh, everyone's quickly getting their answers in now. Okay. So, I don't think I need to spend long on this. Allergic conjunctivitis, pruritic, watery discharge, glassy eyes, and it's recurrent. It's not acute. This should be one of those questions in the Kahoot where everyone answers like as soon as the answers pop up. If you've done GP, that is. Don't even need to say anything. Yes, definitely acute angle closure glaucoma. Older woman, severe pain, sudden onset, often in a darkened room and the pupil dilates and it decreases that iridocorneal angle. So watching television in a movie cinema, and the vision is extremely poor. It's not corrected with a pinhole. Okay, I'm going to see how we did. Yes, so anterior uveitis, ankylosing spondylitis is what's going on in this case. This is a hypopyon, white blood cells in the anterior chamber, which is very characteristic of anterior uveitis. There's also this perilimbal, perilimbal or ciliary flush, which is where the hyperemia is located. Yep, so this is the flame and thunder fundus with papilledema, and that's the characteristic image that you see with the central retinal vein occlusion. Here we are. So chronic open angle glaucoma, what you're seeing here is the optic disc cupping. So this lighter area within the whole of the optic disc, the ratio there is increased. So looking at this distance here compared to the, oh gosh, this is very difficult. So that distance there of the brighter area compared to the entire optic disc normally should be around 0.3, so a third of that, the total width. When it's greater than that, particularly above 0.6, that's suggestive of chronic glaucoma. It's familial. Central vision is relatively preserved, which is why that visual acuity is not too bad. It's the loss of peripheral vision, which is what is how it starts, but then it will encroach gradually upon central vision, and it's irreversible. Oh, no. Yep, so this is age-related macular degeneration, straight lines appearing wavy in an older person with a few lifestyle risk factors. This is the retinal atrophy around the macula, and these little white, yellow spots are drusen to like lipid deposits. Again, a lifestyle improvement is the cornerstone of management so this is probably dry macular degeneration. When there's neovascularization and it's wet macular degeneration, then you can start the anti-VEGF injections. So this is rosacea, persistent and erythema that transiently worsens with telangiectasia, no open or closed comedones, which differentiates it from acne, and in that Ace of Clubs distribution, so mostly on the cheeks and on the forehead. You just treat with sun avoidance, avoid triggers, and then you can use topical metronidazole or oral tetracycline. Okay. Yes, pityriasis versicolor. It's a fungal infection with a Malassezia yeast. It's treated with topical antifungal like selenium blue or Selsun blue shampoo or topical ketoconazole, either cream or shampoo, and results in these hyperpigmented areas that won't fade as tan elsewhere on the skin fades, or they stay hypopigmented when the rest of the skin tans. And more common in tropical environments. So this is seborrheic dermatitis. Significance of HIV there is that it is associated with HIV and Parkinson's disease, which is bizarre, and I don't know why, but it is. So it is the most common cause of a butterfly rash, and it appears on skin with abundant sebaceous glands and appears like a scaly and greasy rash, which is a little bit difficult to appreciate here, but if you zoom in, you do see a bit of that scale. Yeah, so face and scalp are common locations for it. Yeah, so actinic keratosis, which is like a pre-SCC. So The vast majority won't become SCC, but a lot of SCCs start with this sun damaged lesion. It's got a yellow crumbly crust and it appears classically in an older person who's very pale and has a history of sun exposure, like a farmer would. I just gave you a lot of chronic disease information there, got a bit carried away writing the question, as none of it was relevant. Yeah, so superficial spreading melanoma, it's the most common form of melanoma, about 60%, and tends to appear on areas of intermittent sun exposure. So in women, this would be the legs, in the men, common on the back. It has an asymmetrical, if you do the A, B, C, D, E rule, it's asymmetrical borders, a little bit irregular here. It's got different colours throughout it. Its diameter is more than 0.6 centimetres, and it's been evolving or changing. Also would recommend knowing Breslow thickness. Well, that was probably more of a third year thing anyway, but yes. So this is an intradermal nevis. It's a totally benign proliferation of melanocytes, and in the so there's junctional compound and intradermal nevi, and so intradermal is the most differentiated end of that spectrum. Very low risk of malignancy, can be removed for cosmetic purposes, but you wouldn't be doing it because you're concerned of a malignant transformation in the future. Yeah, so no investigation. It's a tricky one. In The reason for no investigation is it just sounds like a radiculopathy, like sciatica. It's a very classic history in someone who does not have risk factors for a more sinister cause. So there's no, that age of 36, it's fairly reassuring. It's when you're sort of above 55 that sciatica becomes less likely to be worried about malignancy. There's no mention of IV drug use or a fever that might suggest there's some spinal abscess that's happening at the same time. There are motor signs, but they're mild, and there's no bowel, bladder disturbance or sensory deficit. So in this case, it would be appropriate for no investigation at this stage, but if anything changed or it didn't improve, particularly within, maybe after 2 weeks, if you'd had no improvement or a worsening of the focal neurological signs, then yes, you would probably do an MRI spine. Okay. Oh, I knew this was going to be controversial. Okay, so this is a tricky one to defend because I got Dr. Claire Harrison from the Department of General Practice to look at these questions, and she again said it could go either way, MRI spine or a spine X-ray. I did look up guidelines, and I'll post a link in with these questions when I upload them, that said your first line investigation would be an X-ray. If you're not worried about if there's no neurological signs and you're not worried about any impingement on the spinal cord or cauda equina. If you were, if that was in the history or examination, then yes, you would do an MRI spine. But when you're concerned about just the bony metastases without any spinal cord involvement, then your first investigation would be an X-ray of the spine. Yes, so this sounds a lot like hip osteoarthritis, in which case your first line investigation will be an X-ray. Oh, is there a question? No. Oh, I skipped a question, did I? Thank you. Ah, perfect, thanks. So accepted CRP or ESR. This is a case of polymyalgia rheumatica with this shoulder girdle pain and constitutional symptoms as well. So yep, just treat with high dose steroids, often for months, if not years, and try and slowly wean. Where are we? So oral prednisolone in this case. So this is a mild to moderate exacerbation of asthma, likely precipitated by a viral ERTI, so no need for antibiotics. He's speaking in full sentences. He's probably a bit tachycardic because he's had salbutamol. Respiratory rate, borderline tachypneic. Oxygen saturation is not too bad either. So the most appropriate next step would be about a 3-day course of oral prednisolone and then cease after 3 days. Yeah, this is a LABA-LAMA combination, just FYI. All right. Yes, so I think the tricky part there was that he's already on a LABA, and hopefully in an that's good. In an exam question, you might be told what is a LABA and a LAMA, not just given names. But he meets the criteria for an inhaled corticosteroid, which I think everyone who chose CLD understood. He's had at least 2 exacerbations in 12 months and FEV1 less than 50%. So the risks with an inhaled corticosteroid in someone with COPD is an increased risk of pneumonia, but in someone who meets those criteria, the benefits outweigh the risks. Yes, so the next step in the management of stable angina would be to add atenolol. So BNC is like the acronym for stepping up therapy. So starting with a beta blocker, so atenolol or metoprolol, then going to long-acting nitrate, that's the N, and then finally C being a calcium channel blocker. So you'd want a dihydropyridine like amlodipine if you're going to add it to a beta blocker. If you can't use a beta blocker in that first step, like atenolol, so say she had COPD or another contraindication, you could use a non-dihydropyridine as that first step in the management of stable angina. Oh, yes, sir? I have bisoprolol as an option. Well, I suspect it has to do with... I will get back to you on that because I don't want to say the wrong thing and I don't know. So... Okay, that's probably why I put it as the answer, because that's what ETG said. It would have to do with the beta receptors that it's selective for, but off the top of my head, I couldn't tell you why. I'll see if I can find an explanation, though. Yeah. Yes. Yes, so in the management of stable angina, the add-on therapies, you start with a beta blocker. So as per ETG, atenolol or metoprolol. Then you'd add a long-acting nitrate. So that'd be like a transdermal, not the sublingual, but like a transdermal patch that someone wears for 8 hours or 16 hours a day, I think, and then 8 hours off. And then finally, so B, N, and then C is a calcium channel blocker, and it's if you've got a beta blocker, then you go for a dihydropyridine calcium channel blocker like amlodipine, not one that's cardiac selective. But if you couldn't use the beta blocker in that first step, then you can use a cardiac selective calcium channel blocker, but you wouldn't then add a dihydropyridine at the end. You can't have both. Yes. Yeah, that's a good point. And in reality, probably you'd check her blood pressure, and if it was still high, then that might be a case of like killing two birds with one stone. But if her blood pressure is well controlled, then given that a beta blocker's first line, you'd probably go for that, because that, given its first line, it suggests it's more effective than the calcium channel blocker. And if her problem is angina rather than persistent hypertension, then go for a beta blocker. Yeah, but good point. Check the blood pressure. All right. All right. So Finafibrate, indicated in the treatment of isolated hypertriglyceridemia. So in the presence of normal cholesterol parameters otherwise, elevated triglycerides, Finafibrate. Ooh, okay. No. Autoimmune hepatitis. So this is a predominantly hepatitic picture with the LFTs. What else do people go for? Yeah, PBC, I thought that would be the other one. You tend to get more of a cholestatic picture with LFTs in PBC. They're mildly elevated, but the AST and ALT are proportionally much more elevated. And you would expect with that degree of inflammation in the liver, there would be some elevation of ALP and GGT, but it's not due to cholestasis. Hemochromatosis, yeah, I don't have much more to add apart from this is every stereotypical clinical feature put into an EMQ. Wilson's disease. I didn't say Kaiser-Fleischer rings. I suppose that would be Wilson's disease. Otherwise, I can't defend it beyond that. Oh, perfect. I don't need to say anything. Yeah. MRI brain. Don't image this woman's brain. These are tension headaches, no investigation required. ECG. Oh, okay. All right. Controversial question. Okay, so this sounds like digoxin toxicity with hypokalemia. So with hypokalemia, which is the reason for doing the ECG as your most immediate investigation, to see whether there is an arrhythmia due to cardiac toxicity. Yes, you would do UECs, but if you had to choose one, I'd put the ECG more urgently, given that you have a good inkling of what's going on already. What you need to know is whether there is if there's an arrhythmia happening. Yes. True. He's on rivaroxaban, so technically he's therapeutically anticoagulated, even though he has AF. He does have other vascular risk factors, so he could have a thrombotic rather than embolic stroke. I think the lack of, I mean, I guess it could be a posterior circulation stroke, but he doesn't have focal neurology. The nausea and weakness for 2 days is very vague. So I think what this question is getting at is more digoxin toxicity and hypokalemia. Yeah, but I understand where you're coming from, and I don't think you're entirely wrong with that. I think it's quite a good thought. Okay. All right. So yes, new sexual partner without using barrier contraception, thinking in an STI rather than bacterial vaginosis. And chlamydia is, well, both chlamydia and gonorrhea, most likely they're going to be asymptomatic. If they are symptomatic, the stereotype is that chlamydia will be more of a watery discharge and it's sort of a subacute onset, so more several weeks since they contracted the infection, whereas gonorrhea, it'll be sort of hyperacute, so within a few days, and it's more of a purulent discharge. So that's why it's chlamydia, yeah. Okay, this is actually syphilis. And yes, the presentations can be very similar. What is unique about syphilis, though, it's this maculopapular rash on the palms and soles. That's very classic secondary syphilis. But otherwise, yes, that history could be very similar to HIV. Yes, so this sounds like psychogenic erectile dysfunction. This is a relatively young man with no vascular risk factors, no medications, he's not got hypogonadism, and he's got a psychosocial stressor in his life, so no investigations. All right, this is a mean question because RACGP guidelines say that in someone with symptoms of BPH, the only investigation that everybody needs is urinalysis to exclude an easily treatable cause of their symptoms like an infection. And also to look for microscopic hematuria, and if you found hematuria, then you would be evaluating for malignancy, be it prostate or bladder or renal. PSA is, if someone requests it, then you can give it, but it's not routinely used. However, I wouldn't worry too much about knowing the guidelines for this, because even when I was talking to Dr. Claire Harrison about this question, she was not impressed by it. So I don't think you'll be getting a question like this on your exam, I'll just say that. But if you're interested, when I post this, you'll see the link to the guidelines that are referenced there, and it just says urinalysis as the one investigation everyone needs. Yes, spironolactone, it's the anti-androgenic effects causing gynecomastia. Just changed to aprenolone, which has a similar mechanism of action but doesn't have the same side effect in as many people. Aprenolone, to make sure I said that right. Eplerenone. Did you catch that? Eplerenone. So eplerenone. Yeah. Don't think that's ever come up in an exam. Something a cardiologist taught me, so don't think it's going to come up. But yeah, good to know. Oh, so which drug is most likely causing this presentation? So it's not diabetic neuropathy. Oh dear. Okay, so this was metformin. All right. So what's happened here is a metformin-induced vitamin B12 deficiency. I don't know if you're aware of that being a side effect of metformin, but it's one of the ones, so gastrointestinal disturbance, lactic acidosis in someone with renal impairment, and B12 deficiency are the three side effects of metformin to use in your counselling of someone in whom you're going to commence it. So recurrent falls at night is the sort of the presentation there for a B12 deficiency because of that subacute combined degeneration of the spinal cord. They're relying on vision instead of proprioception for their gait. And so at night time, when you no longer have that visual input and proprioception is impaired, that's when you're more likely to fall. Yep, so for metformin, gastrointestinal disturbance, lactic acidosis in someone with renal impairment, and B12 deficiency, vitamin B12. All right, we're lowering the bar of students answered to 50 before we get the answers. Oh, okay. So this man is constipated. He has a lot of risk factors for constipation. He's on opioids, he's immobile, he's got poor oral intake, and small amounts of liquid stool is likely overflow incontinence from constipation. So in this case, you need to treat the constipation with a laxative. Caloxyl and Senna is the most commonly prescribed stool softener and laxative combination. So subcut haloperidol, what everyone go for? Oral ondansetron. So this person has had in like a complete bowel obstruction, and so you're looking at giving parenteral medications. You give, for a bowel obstruction, something that is centrally acting, not prokinetic like metoclopramide, and haloperidol is indicated in that case because it's centrally acting if you're given subcut. On Dansitron, I suppose you're thinking like the wafer form. I just know that as per ETG, if there is a bowel obstruction, it's haloperidol. Yeah. On Dansitron, really, certainly for exam purposes, will be someone with chemotherapy-induced nausea and vomiting. Yep, diazepam to prevent progression of his withdrawal to delirium tremens. So, naltrexone. So you've identified the 3 drugs used for treatment of chronic alcohol abuse. Disulfiram requires really good compliance because it can be quite toxic if somebody drinks alcohol while they're taking that drug, and she's relapsed in the past and is worried she can't stay abstinent, so you'd avoid that. Acamprosate is, this is a tricky point, it's 2 tablets 3 times a day. So it requires really good compliance in someone who's happy to take medications multiple times a day. Also, it's not as good in the acute phase for cravings. So that is what's caused her relapses in the past, and cravings are best targeted with naltrexone. We're almost there, by the way. 5 more questions. So, okay, influenza. What did everyone go for? Pertussis. Okay, so For the pregnant woman herself, she needs a pertussis booster with every pregnancy, but for the rest of us, it's every 10 years that we need a pertussis booster. Pneumococcal vaccine is just, if you're over 65, it's just one dose. If you don't, unless you have chronic disease or you're Aboriginal and Torres Strait Islander, then you would get a second dose, maybe a third. But he is otherwise healthy, so one pneumococcal vaccine is fine. Everyone over 65 should get the flu vaccine every year, and it's government funded for them. So flu vaccine. So yellow fever, it's required for entry, mostly entry back into Australia after travelling to certain parts of South America and Central America and Africa as well. So he's had a flu shot, he's had Hep A and typhoid 3 months ago. If he's never had Hep A before, then he will require a Hep A booster to get that lifelong immunity, but it needs to be at least 6 months from the first dose. So too soon for another Hep A, and he's still actually, but that would just be for that lifelong immunity. He's actually covered for Hep A and typhoid for like 3 years if that's all he gets. So yellow fever. Oh yeah, get your reading glasses out for this one. Not a good idea. I think it's probably useful to know all these other strategies in case you get a domestic violence OSCE station and you need to put together a safety plan. So they are all aspects of a safety plan that you would discuss. Last two questions, nice and easy ones to, well, easy. If you know your medical records, they're easy. If you don't, they're hard. Yes. So for adults, you need to retain their medical record for 7 years. So in his last attended 2 years ago, you've got 5 more years to go. Last question. So in children, it's 7 years from when they turn 18, so until they're 25 years old. She's 10 years old, so you're looking at another 15 years of medical records. Okay. All right, that finishes the EMQ session. I'm aware it is 4 o'clock. I'm sorry that this has gone so late. Can I just, to get an idea, have a show of hands, who's going to stay to practice OSCEs? It's not a huge number. Would you prefer to stay in the lecture theatre here rather than move across to 27 Rainforest? Okay, that's a yes. Okay, that's fine. We can do that. So it will save some time. We can just get straight into it in that case. All right. Thank you very much for coming and staying. It's been a long day. You've all done very well to get to this point. I hope you've learned something. And as I said, if you have any more questions, feel free to get in contact. You can jump down now or send me a Facebook message or send me an email. Okay, thanks, guys. Oh, actually, I will talk briefly about a 10-step management plan. If you know this, feel free to leave. I will not be offended. But this is probably, yeah, just leading into the OSCE session. So I'm happy for you to go. If you could just leave like a little bit quietly, that would be good so that I can run through this with people who would like to hear about it. So a 10-step management plan is the framework that you use in any GP OSCE station that requires a management component. It's basically steps 4 and 5 are where you'll be doing the majority of your talking. So step 4 is educating the patient. Step 5 is actually giving them the management plan. All the other steps you can smash out in about a minute collectively. So it's one sentence to tell the patient their diagnosis, ask them, what do you know about this? Ask them, how do they feel about this? And then you get into your education. Always offer a visual aid when you're doing that. Management, you break into immediate, short-term, long-term and preventative, and always lifestyle, medications, surgery. Prevention, so in every GP, if appropriate, in a GP OSCE station, you'd be expected to talk about a preventative opportunity like giving the flu vaccine or discussing healthy lifestyle or checking somebody's blood pressure, calculating their cardiovascular disease risk. You wouldn't do it in an emergency consult or in a domestic violence consult, but otherwise you do try and incorporate that in. And then the rest of it, again, you smash out really quickly. So you ask, can you repeat back to me the most important parts of what we've spoken about today? I will get you a pamphlet from the Better Health. I'll print out something from Better Health channel for you to take on your way out. It's just takeaway information. Evaluate the consult, again, just as it says, do you have any other concerns? Is there anything else today? And then follow up. You always arrange when you're next going to see them, and safety net. So that's, if this happens, do this. So they've come in for management of their angina. If you get chest pain that doesn't respond to the nitrate, or you start to feel nauseous and sweaty or something's not quite right, you go to ED. That's safety netting. And that's what you do at the end. So this is like a 10-step management plan explained in 30 seconds. And a lot of it you would already be doing. It's just a matter of making sure you tick off those steps. So if you get a GP OSCE station, what I recommend that you do in your reading time is you write down steps 1 to 10 and your mnemonic for remembering that, and you just have that in front of you in the station so that you can tick each of those off as you do them. And as I said, you'll still be focusing mostly on education and management, but there might be half a mark for everything else. But collectively, that adds up to like 4 marks that you don't want to miss out on. So you just need to make sure you say a sentence to each of the other steps in the management plan. And that's it in a nutshell. Thanks for sticking around for that. Now we'll go to the OSCEs. Okay.